Hello all, and welcome to this presentation on my current existing working model for treating clients with PTSD. I have chosen internal family systems informed eye movement desensitization and reprocessing therapy as my approach. This presentation will include material on post-traumatic stress disorder, EMDR therapy, IFS therapy, IFS-informed EMDR, cultural information, religion, spirituality, and Christian worldview considerations. EMDR therapy will be presented in conjunction with IFS therapy as my own existing working model for treating clients with PTSD. This section focuses on post-traumatic stress disorder, or PTSD. PTSD first appeared in the DSM-3. There is much debate on what qualifies as a traumatic event. Exposure to multiple traumatic events is common, and rates and symptoms differ across trauma. PTSD is a debilitating condition that is prevalent and disabling. Associated symptoms and problems of PTSD include depression, dissociation, somatization, affect dysregulation, and disrupted self-perception. There are several DSM-5 criteria for PTSD. These include the following on the graphic shown. Complex PTSD, or CPTSD, is in the same diagnostic entity as PTSD in accordance with the International Classifications of Diseases, 11th revision. CPTSD is a severe form of PTSD that is a result of prolonged and repeated trauma. I will use several measures in my working model for treating clients with PTSD. In order to determine if a client can be diagnosed with PTSD, I will use the Life Events Checklist in conjunction with the PTSD Checklist, DSM-5 version, Clinician-Administered PTSD scale for DSM-5, or the Post-Traumatic Stress Disorder Symptom Scale interview for DSM-5. While completing my research, I came across a quote by Brigadier General Laurie Sutton, who stated, "We were not allowed to speak of the unseen wounds of war. We were not allowed to prepare for them." This is near and dear to my heart. As you can see, I was deployed to Mosul, Iraq, 2011 in support of Operation New Dawn. This section will focus on eye movement desensitization and reprocessing, or EMDR therapy. EMDR therapy was discovered in the late 1980s by Dr. Francine Shapiro. EMDR is a psychotherapy and behavioral approach for PTSD that involves bottom-up processing. EMDR is based on the theory of adaptive information processing. EMDR utilizes a multimodal treatment strategy that is therapy for the body, therapy for the mind, as noted by Shapiro and Forrest. EMDR has shown efficacy in treating both children and adults and is one of the most studied treatments for PTSD. EMDR is an empirically validated treatment approach. So what does EMDR do? EMDR helps the client to process upsetting memories, thoughts, and feelings related to their trauma. EMDR helps clients process their trauma. EMDR also helps the clients make sense of what happened to them, and EMDR allows the client to begin to heal. This graphic is provided by the Lighthouse Recovery Institute. There are several training facilities for EMDR. The main one is the EMDR Institute Incorporation, founded by Dr. Francine Shapiro. This provides EMDR methodology training. Training includes lectures, demonstrations, and supervised practice. Supervised practice includes observation and feedback from EMDR Institute Incorporated trained clinicians. Other training resources include the Soldier Center and EMDR International Association. This next session will cover internal family systems, or IFS therapy. IFS was founded by Richard C. Swartz in the 1980s and sees PTSD symptoms as an individual's best attempt to survive and cope with distressing and overwhelming emotions and memories. IFS is based on psychotherapy model and systems therapy and experiential approach combined. Others believe that IFS is a combination of general systems theory and intrapsychic concepts. IFS is an evidence-based treatment for PTSD. During IFS, the internal attention of the client is focused on thoughts, feelings, and physical sensations. IFS therapists use a non-judgmental approach. There are many IFS beliefs. One is that the practitioner uses self or self-energy. Self is broken down into 8 C's according to the Internal Family Systems Skills Training Manual. In IFS, it is believed that an individual has parts. These parts are broken down into 3 categories: exiles, managers, and firefighters. The parts protect self at all costs. The self is one's consciousness and runs one's behaviors and attitudes. Parts of an individual protect them from emotional pain, such as alcoholism, addiction, eating disorders, risky behaviors, and being a workaholic. So what does IFS do? IFS minimizes chronic social stress, regulates shame, and increases self-acceptance in the client. IFS assists enhancing ability to attend to difficult or distressing internal experiences mindfully. IFS helps the client to tolerate and process traumatic material. Training for IFS is provided by the IFS Institute. There are 3 levels of training ranging from beginner to advanced. Attendees learn IFS theory and technique. Attendees will also gain knowledge and skills to understand and actively use IFS. According to the IFS Institute, there is currently a high demand for IFS training. Slots for applications are filled using a lottery system. This section will focus on my own approach, IFS informed, EMDR based, on an adapted protocol provided by Gillian O'Shea Brown. I chose to go this route because the models share a common approach, and both models activate the healing process. After completing the aforementioned PTSD measures and religion spirituality measures that will be discussed shortly, I will begin by utilizing the initial phases of EMDR, which include history taking for treatment planning, client background, and the client's suitability for EMDR. During this process, I will begin to implement IFS by using IFS language, listening reflectively, and engaging with the client. I will repeat back what I believe the client stated and feels and request feedback from the client on the accuracy. I will provide the client with psychoeducation. During phases 1 and 2, the client will begin self-exploration and learning acceptance of the multiplicity of the mind. I will provide the client with the tools necessary in order to prepare them for EMDR therapy. I will identify a target to treat based on information provided during the history taking session. The self states identified through IFS can assist with identifying a target. I will use IFS as gentle, affirmative language along with EMDR's bilateral stimulation and focus strategies. During phases 3 through 5, I will begin working on achieving trauma resolution with the client. This is accomplished through reorganizing parts, giving the parts a voice in order to express their needs within the internal family system. In this phase, I will ensure that I support the client as the client begins to move towards internal harmony. The client will develop self-readiness during these phases in order to tolerate EMDR processing. I will assist the client in increasing their connection between positive cognitions and adaptive neural networks. IFS managers and firefighters may appear during EMDR treatment and can have therapeutic backlash. As the therapist, this is something that I must be mindful of, as well as my own affect, thought process, and countertransference. The final stages of this adaptive protocol are 6 through 8. I will continue IFS-oriented psychoeducation with the client. Gentle navigation of the mind-body relationship of the client will ensure client stability at the end of treatment. I will reevaluate the client using the previously discussed IFS language. There are many recognized definitions of culture. There are many cross-cultural dimensions to trauma. Culture influences an individual's thoughts, feelings, and behaviors. There are several cultural indicators such as race, ethnicity, nationality, citizenship, gender, gender identity, sexual affectional orientation, socioeconomic status, religion, spirituality, ability, disability, and age. I believe there are several important factors that I gained from the research I completed while preparing this presentation. The God concept is one's cognitive knowledge of and beliefs about God. This is how one thinks about God. It may be influenced by teachers, parents, formal or informal education, and books. God's image is one's emotional experience of God. This is how one feels toward God. This is also how one feels that God feels toward him or her. This may be influenced by early experiences with one's significant caregivers. Spirituality is a highly individualized concept. Spirituality may or may not be expressed through organized religion. Spiritual meaning is an important factor in post-traumatic healing. Through my research, I found I was quite inconsistent regarding PTSD and religion. I also found that spiritual distress and moral injury are comorbidities of PTSD, and veterans who experience moral injury are at a higher risk for suicide. During my research, I found that the loss of faith equals the possible loss of effectiveness in treatment, and that spiritual distress may exacerbate PTSD symptoms. There are three main spirituality issues when treating clients: their shifting relationship with God, the nature of hope, and their sense of identity. This slide provides information on what I will not do and will do as a clinician or practitioner. There are several measures to determine religion and spirituality. This set of questions shown is the first that I will ask the client. The client will then be evaluated using the Belief in Action Scale, or the BIAC. This is a 10-question measure that assesses the client's degree of religious involvement using a 10-point scale. There are several considerations when it comes to religion and spirituality. Some scholars suspect that IFS has very limited connection with the study of religion, although the research shows that IFS therapy has implicit religious values and shares similar values as religious studies. Research has shown that images of God may change during EMDR therapy. How I treat my clients may be based on my own past experiences. An individual's body tells us what words cannot. I will be mindful of this when engaging with my clients. I will address my client's trauma for what is impacted the most. I will ensure to pay attention to spiritual distress and moral injury, as they both require clinical attention. In order to be mindful of culture, I will use a cultural lens when treating and engaging with clients.